So we'll talk about the bad side of ultrasound in cardiac arrest. So this is your emergency department. This is the main corridor of the ED. You are working at a night shift. This is actually the, so I don't know. So this is the main area, the critical care area. You are working there. It is a quiet shift. You have like scattered cases of chest pain, abdominal pain. Otherwise, it's quiet shift. On the other side of the emergency is the observation unit. This is a unit where you keep the patient for short stay, for observation, but actually you have many patients admitted under other services. One of them actually is this patient. This is a 65-year-old male, admitted just a few hours ago under neurology service as a case of TIA. Has multiple neurological complaints every now and then for just like few minutes. During the monitoring at 2 a.m., the nurse came to the bedside to check the vitals. The patient actually was unresponsive, has no breathing, and has no pulse. So immediately, the code blue was announced. You moved from that quiet area to this observation unit. And CPR actually was started with the patient. The patient was attached to monitor. The monitor showed shockable rhythm, VTAC in the form of torsade depointing. So next, the team is coming. So more people are coming at the bedside of the patient to establish the CPR team. Actually, American Heart Association recommends many interventions, but actually would work only few of these interventions. It is the high-quality CPR, the early defibrillation, and the targeted temperature management, and of course, if there is any cause of cardiac arrest, you need to know that cause and reverse it, if possible. Usually for you and for your team, establishing early defibrillation, targeted temperature management is not a big deal in general. But what is big deal, what is challenging is this one. Delivering high quality CPR. So what is high quality CPR? High quality CPR means the rate is the proper rate, 100 to 120 chest compressions per minute. The depth, 5 to 6 centimeters with a full chest recoil. But the biggest challenge is this. Make it continuous without interruptions, or let us say without any unnecessary interruptions. Actually, there are many what you call enemies for interrupting CPR. Unfortunately, these are the things that we do for our patients. Things like checking the pulse, bagging the patient, intubating the patient, switching between CPR providers, and doing ultrasound. So the good news, there are simple measures we have to pay attention to avoid the interruptions. For example, checking the pulse, assign someone with the femoral artery, even during the chest compression. During the 10-second of pulse and rhythm check, that provider is able to give you the answer, do we have pulse? Yes or no. Bagging the patient, it is 30 to 2 recommendations, but you do not have to stick to this one. Okay, there are many institutions, they do it asynchronously, which means you have a chest compression with a specific rate, not related to the bagging. You have a bagging to specific rate without any relation to the chest compression. Probably that will minimize the interruption related to bagging the patient. Intubating the patient, as have been discussed before, as long as you are able to bag the patient initially, probably that is enough. If you have to intubate the patient, you do not have to stop CPR. Or you can intubate the patient during the pauses for pulse and rhythm check. Switching between CPR providers, do it after 2 minutes. If you want to do it, plan it very well. Okay, the one who is doing chest compression should announce it 3 to 1. Next provider should jump to the patient chest and take over that chest compression role. Doing ultrasound, so here's the topic. Ultrasound is the enemy for high quality CPR. So really what a painful slide to make. ultrasound is the enemy for our patient. So is it true? Is ultrasound the enemy for our patient with cardiac arrest? Actually, this is what had been shown by studies, so let us scan these quickly. The first one, in resuscitation, October 2017, ultrasound used during CPR is associated with delays in chest compressions. So it was a prospective study, ED patients. All these events, almost 123 events, were videotaped to calculate the outcome, which was the duration of pulse check with ultrasound and without ultrasound. We want to compare the two groups. So what was the result? Without ultrasound, it was 13-second pauses average, which was longer than American Heart Association recommendation, which was maximum of 10 seconds. What about with ultrasound? Almost double, 21 seconds, with significant difference between the two groups. Another study, again from resuscitation in January 2018. I don't know, it's like clicking by itself. Point of care ultrasound used in patients with cardiac arrest is associated with prolonged CPR pauses. So you get the result from the title. Again, prospective study, ED patients, 110 events. The primary outcome was the same, the duration of pulse check with ultrasound and without ultrasound. So what was the result? Without ultrasound it was marginal, 11 seconds. With ultrasound, again, it was longer. So again, another study telling us using ultrasound at the bedside with a patient with cardiac arrest associated with prolonged pauses. And that is surrogate marker for worse outcome for our patient. So again, back to the question, is it true that ultrasound is the enemy for our patients? So this is the best of emergency medicine. So I came here to tell you that ultrasound is harmful and you shouldn't use it. Probably there is still more to the story. So these provide us with the data. Data will give us information. Information will give us knowledge. If we want to limit ourselves to this level, yes, I would say no to ultrasound in cardiac arrest. But actually, there is something called wisdom. Is there a place for wisdom here? Okay. Ultrasound is a two-sided weapon. Like a knife, you can harm people. That is a bad thing. But actually, you can invite people to dinner or lunch, which is a good thing. So don't forget about the other side of the story, other side of the picture. Ultrasound is associated with a lot of benefits. Do not forget about these benefits. So with ultrasound, we can know, do we have the pulse, the true pulse? Ultrasound will tell us about the H's and T's, the causes of cardiac arrest, which is actually a big achievement for your patient. Ultrasound will help you to have prognosis about the patient. Should you continue chest compression, CPR, ACLS, or should you stop there? So the true and false pulse, or true PEA, pulseless electrical activity, and pseudo PEA. These are two patients. Both has no pulses. This patient, there is no heart activity. This is a patient who needs chest compression, definitely, okay? Regardless that the one who is in femoral artery tell you do you have pulse. Actually, there is no cardiac activity. While this patient, actually, this is a patient with a profound shock. You didn't feel the pulse because the pulse is so weak. Maybe it's so weak, or maybe the patient habitus didn't help you to figure out do you have pulse or not. This is a patient probably will benefit from vasopressor, from looking for cause of shock, probably not from chest compressions. Ultrasound help us to figure out the causes of cardiac arrest. Again, this is like really big advantage of ultrasound. There is no other tool that will tell you the causes of many of these items here other than the bedside ultrasound. Ultrasound can help you with tension pneumothorax, tamponade, aortic dissection, hemothorax, positive fast, DVT, and actually the list is even longer than this. Ultrasound help you to decide should you continue CPR or stop CPR. Of course, it is not the only parameter that you will rely on, but actually one of the main player for your decision-making process for your patient, as long you don't have reversible cause. This is a patient with standstill. There is no movement of the heart. You know the prognosis almost zero, unless you have, of course, reversible cause. So definitely it's associated with a risk. Definitely it's associated with many benefits. Using ultrasound at the bedside. So what is the solution? What's the deal here? Actually, we have simple measures, 6 simple solutions that you have to pay attention to minimize the risk of using ultrasound while keeping all the advantages of ultrasound during resuscitation of cardiac arrest. First, do ultrasound only during rhythm and pulse check. Do not use ultrasound just because ultrasound came to the bedside. Use it with a proper time. It's the time for rhythm and pulse check. After 2 minutes of CPR, there is 10 seconds to answer 3 main questions. So what is the pulse? Do we have it, yes or no? What is the rhythm? Do we have shockable or non-shockable rhythm? And what does the heart is doing? What is the heart is doing? Okay, do we have like good squeeze, we have PE, we have tamponade, etc. The second, do ultrasound while CPR is running. So is it possible someone is compressing on the chest and I am doing ultrasound for the patient? Actually, the answer is yes. You can look for pneumothorax while CPR is going. You can look for hemothorax for positive fast while CPR is going. You can look for aorta for DVT while CPR is going. In fact, you can do even cardiac while CPR is going on. Even subxiphoid, you can just place the probe is there while someone is compressing the chest. It will not be the ideal image, but actually will have a hint what is going on there. 3, do ultrasound while counting down. So assign someone to count down from 10 till 0. So 10, 9, 8, 7, 6, etc. Once the 0 time arrives, you have to stop. You have to resume CPR, whether or not you get the result that you need or the views that you are looking for with ultrasound. So that is a rule. Just move on to the chest compression. Keep the decision to resume CPR with the CPR provider, not with the ultrasound operator. Actually, the ultrasound operator is the worst team member who will decide about resuming CPR because they will not resume it unless they get the good view, which doesn't make sense. That is not for the benefit of the patient. Keep that decision either with the team leader or the one who is ready to take over the chest compression rule. This is a magic underutilized button for ultrasound machine. So utilize the 10 seconds to achieve the image, only to achieve the image. Save these images, save these clips, then resume CPR, then you have the clip with the machine. You can review the ultrasound clips and get the interpretation part. So utilize that 10 seconds only for image acquisition. Keep the interpretation later after you assume the CPR. The last, this is coming to our practice, I hope soon, and stay tuned. There will be like fantastic topic coming probably after 1 hour. So the take-home message. So ultrasound is two-sided weapon. Yes, associated with harm with pauses, but do not forget about the benefits. So it depends about how to use that tool. It's a safe, efficient tool in a safe, efficient hands. I believe your hands are safe and efficient. And I think we came to the end. Thank you so much.